time, it's not that easy to distinguish straight away, because it's great if this is someone presents for the first time in their life with a really nasty migraine, with all the characteristics of a migraine. That's wonderful. You can treat them and then you can get them home and they feel a bit better. But secondary headaches are a different story. Very often they're due to structural abnormalities in the brain or adjacent tissues, and potentially quite risky conditions that you really don't want to miss. Generally speaking, if you do scans on people with headaches, the yield of imaging is generally quite disappointing. And the only way of being clearer as to who does or does not need imaging, we're talking CT, MRI, etc., is it requires some degree of case selection. And I've said that twice on the slide, but that's the point is the same. And the real worry a lot of the time when we would get referred these patients is, have they had a subarach? And the reason is very simple, because subarachnoid haemorrhage, the first one is a headache, the second one might kill the patient, or at least make them extremely disabled. And many other vascular causes causing severe headache are also sort of the unspoken concern. I'm going to talk about them in a minute. Not all acute headaches are thunderclap or rapid onset, but the ones that give us the greatest worry are the ones that come on rapidly. Because they are the more likely to be associated with significant pathology. And of course, subarachnoid haemorrhage is right all the way at the top, because that's your textbook cause of rapid onset or thunderclap headache. Other conditions that fit under the same heading are cervical artery dissection, so carotid or vertebral dissection. Pituitary apoplexy almost universally presents with quite a sudden onset headache. So if you don't think about it, you might potentially miss it. Cerebral venous thrombosis often does not present with a thunderclap, but it might do. Then there's a fascinating group of conditions that are together called reversible cerebral vasoconstriction syndrome. What these patients get is often a cluster of thunderclap headaches, so more than one in a short period of time, with complete or incomplete resolution in between. The old epitome of Core-Fleming syndrome is sometimes used by enthusiasts like me. The way to diagnose, they might actually get a bit of secondary subarachnoid hemorrhage, but you often end up diagnosing them with a CT angiogram showing a beading appearance of the large cerebral arteries. And then there's a couple of thunderclap headaches that are primary, so actually, ironically, are primary headache syndromes, and they're primary cough headache, primary sexual headache. So this is someone comes to hospital with an absolutely stonking headache just after they've had an orgasm, or they were in the middle of intercourse. Now, that might be a subarach, but there is also a primary form that presents very similarly without blood in the CSF, and they can be recurrent. Now, thunderclap headache itself is defined as a time of interval between the onset of symptoms and the maximum severity. And if that's less than 1 minute, according to the French ladies who are experts in this, you call that thunderclap. But some people use 5 minutes, and some purists will say actually thunderclap should be maximum intensity that's momentous, that's within a second of first becoming aware of the headache. So you can see how the definition is a little bit liquid. So subarachnoid hemorrhage then, the one that we really want not to miss in people with acute headaches, particularly if they're quite rapid onset in velocity. Now, subarachnoid hemorrhage is a form of stroke. It fits in the nosological definition of stroke, and a lot of patients with subarachnoid hemorrhages will actually have focal neurology, particularly if they're large volume and could cause hydrocephalus and all those kind of horrible things. It first became a known diagnostic entity on postmortem studies in the 18th century. And it was the 19th century where Byron Bramble in Edinburgh started to describe the clinical syndrome that preceded the diagnosis. So it was now possible, based on the history, to actually diagnose it in life. It became a lot easier when Charles Simons in the 1920s, he was a neurologist in London, also associated with the British Army. He introduced lumbar puncture as a diagnostic test for subarachnoid hemorrhage. And things went really rapidly after that. So in the 1930s, people started doing cerebral angiograms, and they were able to start finding aneurysms. And once an aneurysm had been identified, it became possible to start clipping them, which was done by Walter Dandy in Baltimore in the 1930s. Critical care support became better and better, so neuro-ITU is a very 20th century development. But we learned more and more how to look after brain-injured people which had the ruptured aneurysm. Nimodipine entered the scene, which was the drug of choice to try and prevent delayed ischemia secondary to vasospasm. From the 1990s, we started to find more and more non-surgical approaches. Gugelmi in California started coiling aneurysms that were amenable to coiling. So during the cerebral angiogram, actually plopping little bits of platinum in the aneurysm, and then you get a thrombotic response, and the aneurysm starts to regress. And that means you don't have to cut people's skull open anymore. It's absolutely great stuff. So CT had entered the scene in the 1980s. The first CT scan, for those who were not aware, was built in Hayes in Middlesex. We sometimes get stroke patients from Hayes, and we think, yeah, Hayes is where Geoffrey Newbold Hounslow built the first CT scanner in EMI laboratories. But CT became better than LP, or at least became a less invasive test in the 80s and 90s. Studies from around that time show that it was very, very sensitive, particularly in the early stages. And you see a nice subarachnoid CT over there from Wikipedia. But it was also recognized that the sensitivity was not 100%, and that particular later presentation was associated with a lower sensitivity. So lumbar punctures remained necessary to diagnose subarachnoid hemorrhage in people with acute headache or a suspicion of subarachnoid hemorrhage. And as a result, the guidelines up until very recently recommend LP in all cases with a thunderclap headache or a worrying headache and a normal CT scan. Then in the late in the late first decade of the 20th century, there started to be a concern that we were being excessive in our diagnostic approach, doing LPs on everyone. And the Canadians are great at clinical research, and this is no exception. A team led by Geoffrey Perry in Ottawa started looking first at clinical decision rules and also at repeating those cohort studies about the sensitivity of CT using modern scanners. Remember, an old CT scanner in the 1980s is incomparable to a 32-row detector CT scanner that we use nowadays in our clinical work. So they did two things. They introduced a clinical decision rule called the Ottawa Subarachnoid Hemorrhage Score, and that was to be used in patients with an acute headache to see if you can avoid doing even CT scans. It's almost like PERC for headache, for those who are familiar with the PERC score in suspected PE. Their other work was looking at the sensitivity of CT, particularly in the very early onset, so within the first 6 hours of presenting, 6 hours from the onset of symptoms. So you have to be fairly fast in getting a CT scan done, because these patients might be sitting in your waiting room waiting to be seen by a doctor. What they showed in the famous paper in 2011 was that if you do a CT within 6 hours from the onset of symptoms, reviewed by neuroradiologists, you've got 100% sensitivity. What this means is that you can then not do an LP, because if CT it is 100% sensitive, then all LPs you do are going to be negative. So this is our dilemma on a day-to-day basis in AMUs and acute medical takes all over the country. Is this a patient with headache who needs treatment, and once they feel better, you can discharge them? Or alternatively, is this someone who might have was actually had a sentinel bleed and is going to get another one that's going to land them on neuro-ITU with a pressure bolt, and there may be an organ donor, or they may be in a nursing home, or they're going to die. You don't want to be that doctor who misses the case on the right while doing what you were going to do to the left. So here then is the clinical decision rule from Perry. from the late noughties. So they started a cohort of patients where there's a new atraumatic headache, where the pain came on peaking at less than an hour. So quite a conservative cohort with no neurological deficit, no cranial nerve palsies, no focal weakness, nothing sensory, etc., etc. Not known to have an aneurysm, never had a subarachnoid previously, not known to have brain tumor, and hadn't come back in the last 6 months with this headache a couple of times. And the rule to the right was found to be 100% sensitive, which means that every patient with a subarachnoid hemorrhage failed their checklist in any of these parameters. However, it's only 12.7% specific, so you're still going to have to do other diagnostics. Surprise, surprise. A lot of the patients we see don't meet these criteria, so you're still going to have to investigate them. And they found CT remains very sensitive. So which patients did they think did not need a CT scan, let alone an LP? People who are young, because the risk of subarachnoid hemorrhage goes up with age. No neck pain or stiffness, just pain elsewhere in the head. No syncope that was witnessed. Onset during exertion is a potential trigger for aneurysm rupture, so that was considered a warning sign. Similarly, instantly peaking pain, so there's less than a second. They are purists. So thunderclap means thunderclap, like Brexit means Brexit. If someone reports that, you're just going to have to scan them. And similarly, the presence of meningism or limitation in neck flexion on physical examination. Their other study, and the finding is at the bottom left. So they also found a CT is 100% sensitive in the first 6 hours, and actually remains very sensitive in the remaining 24 hours for aneurysmal subarachnoid hemorrhage. Since that time, Perry and his team have actually repeated their study in a real-life cohort, and they use both these things jointly. So they looked at more than 1,000 patients before and more than 1,000 after, using the clinical decision rule and the CT scan rule to see if CTs and LPs could be avoided. Long and short, they found reduced need for lumbar puncture, but they still needed to do it in a quarter. Admissions went down. If you look at the number of admissions, clearly they were doing the LPs in the emergency department, because the number of admissions is much lower than the number of LPs. No A&E doctor in this country does an LP, as far as I know. The Leeds used to do it, apparently. A lot of these patients had some other diagnosis, so they had LPs or CTAs or both. Length of stay in the ED was unchanged. What they found in this implementation study was that the clinical decision was 100% sensitive, CT was 95.5% sensitive, and the cases missed on CT, one was a misread, two had incidental aneurysms, so that they're not non-ruptures. Not one had a bleed secondary to another vascular lesion, and one had. So this is a very interesting thing that I only learned recently. If your hemoglobin is relatively low, then any blood that goes into your subarachnoid space or your cerebral parenchyma is going to be fairly dark, because what looks white on CT is the iron content. So that means someone with a hemoglobin of less than 100 or 10 in old money, the CT might be false negative, and they found a case. What they concluded was that the combination of the clinical decision rule and the CT scan rule could be used to discharge patients without lumbar punctures, plus minus CTs in many cases. So then we had NICE. NICE published just over 2 years ago a new guideline for subarachnoid hemorrhage, aneurysmal subarachnoid hemorrhage even. So it's quite a constricted definition, but of course it covers the diagnostic phase as well. And they said you should think about subarachnoid hemorrhage as someone presenting with thunderclap headache, neck pain and stiffness, photophobia, nausea, vomiting, low GCS, seizures, focal weakness, and meningeal signs. Okay, we sort of knew that, but they emphasized that it should be in the differential diagnosis. Do a CT scan if there's a clinical suspicion of subarachnoid hemorrhage? Yes, that we knew that too. But, and this was the bombshell for many UK practitioners, that is, don't do an LP if someone's got a negative CT within 6 hours of onset of symptoms. Now, this caused a bit of consternation amongst the neurosurgeons in the land, and they actually put out some statements in the British Neurovascular Group on Twitter. I don't think it was ever a formal statement. But in any case, they said this has not been properly validated. And imagine if you miss a sentinel bleed because the next one might kill the patient. Are you sure you want to do this, guys? So they actually suggested that we continue to do LPs. Interesting. Which sort of set the scene for the study we're discussing today. So thanks for holding your nerves with regards to the preamble, but here is the SHED study itself. So this is a very interesting study for other reasons, and that's the fact that it was conducted almost entirely by A&E registrars. So TERN, the Trainee Emergency Research Network, started almost a decade ago, and it took them a while to get this study selected to do. But it was done on trainee initiative, and we're starting to see more and more of this. So the gastroenterology trainees have also banded together to lead research studies, and there's probably going to be more happening up and down the land. I'm waiting for acute medicine to join in, really. So what did the SHED study want to achieve? So the main question is, we need to validate that CT research a little bit better, particularly based on the concerns of the neurosurgeons that we might be missing cases if we implement Perry's data in the UK setting. Secondary question was, what are the characteristics of CT after 6 hours of onset? Because we're still CTing all the other patients, LPing all the other patients. And can we use the Ottawa score in an unselected UK population? So this was done in 88 type 1 emergency departments. That's almost half of all A&Es in the UK, which is really pretty damn impressive, I have to say. And they recruited patients for almost 3 years, but there was a hiatus for 1.5 years because COVID, that nasty virus that paralyzed everything. And they studied during that period all consecutive patients with non-traumatic headaches. So you want to avoid selection bias. So they looked at consecutive patients who had a headache that developed within an hour. So again, using Perry's CDR inclusive criteria, GSS of 15 and age 18 or over for consent reasons. Identified by A&E doctors and research nurses, and they screened 3,663 patients. That's about right. That's how many headaches we see. And they gather data on the elements from the clinical decision rule, of course, to validate it. They used a simple inclusion checklist to make sure nothing was missed, and they did this prospectively. So a patient presents with headache, use the checklist. So as a result, we're able to capture information that otherwise doesn't necessarily get documented in medical records. So that's a really nice way of optimizing your data quality. Then they looked at imaging results, other investigations, diagnosis at discharge, and consent was by opt-out. So they contacted the patient afterwards and said, do you mind if we use your data? It's an observational study, so I don't think the ethics of that is at all controversial. But they sought consent by asking the patient. And I'm aware of other observational studies that have taken the same approach. So what patients did they not include? Head injury within the last 7 days, because of course the worry is about traumatic subarachnoid blood that's going to mess everything up. Previously attended with the same headache within this period, so it includes the recurrent ones. Previous subarachnoid, no brain tumor. This is again Perry studies. Known VP shunter hydrocephalus, presence of focal neurological deficits. The moment you've got lateralizing weakness or cranial nerve palsy, you're out. Headache started more than 2 weeks ago. Okay, that's a bit long. Recurrent headaches. Again, this is from the CDR selection criteria. Patient was transferred somewhere else. Or people who are prisoners or those detained on the Mental Health Act, because they're just much harder to get good methodological data on. So what were the outcome measures? Of course, before you conduct a study, you want to know what you want to know. So they wanted to know the CT interpretation based on a radiologist, not a neuroradiologist, a general radiologist, as per NICE. Blood on a subsequent study, like a CT angio or an MRI angio, and all the LP results. So, for example, visible centrochromia, CSF looks yellow, or positive spectrophotometry, or a lot of red blood cells in the third bottle, plus an aneurysm found on subsequent studies. If any of that data was unclear, they had a panel that thankfully included the acute medic to work out whether this was a case, whether this was not a case of subarachnoid hemorrhage. A scan that was reported as potential was regarded as positive, as we would do in clinical practice, unless subsequently it was found that it was a false positive. That's fair enough. I'm going to skip the statistics because I'm not all that skilled in telling me that these are the right tests, but I trust that they had the right statistical expertise to choose these statistical approaches to the data set. They had originally hoped to recruit 9,000 patients, so they fell well short of that. They had 3,500 because they wanted to have a very robust confidence interval, but sadly they had to stop at some point because it was getting silly. And here are the results. And I'm sort of going to walk through the diagram, and I realize it's slightly small because the key findings are actually in the wording on the right. The patients on whom CT scans were performed, that's the sort of the group you're interested in, 211 had a positive CT, and this is about the CT positivity you're going to find in someone with a worrying headache. So that it meant the data, it matched the data from the literature of prevalence about 5% in such a headache cohort. They separately looked at those with a low hemoglobin. 36 of them had a low hemoglobin. 6 of these CT scans were actually false positive. There are certain findings that make a radiologist initially say that something looks like a subarachnoid, and they get evaluated further. Turns out it wasn't on further review or further diagnostics. A further 29 cases emerged during further diagnostics. So they did an awful lot of lumbar punctures. If you see the figure, there are more than 2,000 of these 3.2K had a CT. A significant majority underwent a lumbar puncture. So 25 of those had a positive LP. 2 had further imaging of some kind. 1 had a very high RBC in the CSF, plus was then found to have an aneurysm, and only 1 was found later on re-presenting. That's a very rare event, should be a rare event. So all in all, they found 237 cases of subarachnoid hemorrhage, the majority diagnosed on CT, a couple on LP, of whom, interestingly, a relatively small proportion was aneurysmal. So when I previously reviewed subarachnoid hemorrhage, I was taught subarachnoid hemorrhage is caused in 85% by aneurysmal bleeding. And from this study, that is completely different statistics. It was only slightly more than half that were aneurysmal bleeds. The remainder were non-aneurysmal, and a small number were that there generally was no clear cause. So feeding that data into the research protocol, this is what came out. So CT within the first 6 hours is not 100% sensitive. It's only 97% sensitive. However, it is 100% specific, so that's great. That means that a negative CT in someone with a headache that is developed in the space of an hour or so means that the likelihood of them still having had a subarachnoid hemorrhage is 0.5%, or 1 in 200, a negative likelihood ratio of 0.03. They went and looked at the cases that were diagnosed on LP So let me look at those three cases. So the further imaging, they found it in some other way. And they were not actually aneurysmal. If CT was performed later, then the number of false negatives started to go up, but it was still pretty low. And even at 24 hours, there were only 3 false negatives, and only one of those was an aneurysmal hemorrhage. Okay, so that's CT. So CT is really good, isn't it? As we sort of knew, although it's not perfect as Perry's initial studies tried to persuade us. What then about a clinical decision rule? 94.6% of all the cases that were studied had all the data to allow you to calculate the clinical decision rule. So this is the SAH score. That might be a rule-out test without CT. Another couple of percent had enough data to say that the decision rule would have been needs a CT. So that means the sensitivity of that score is a 98.3%, but the specificity, again, and we knew this from the previous studies, is very limited. So what does that mean? That you got a 1.4 post-test probability of still having had a subarachnoid, even if the CDR is negative. Is that good enough? And that's a big problem. They looked at the subgroup, so they looked at the patients who are less than 40 years old, where the pre-test probability of having a subarachnoid hemorrhage is very low because, as I said earlier, it's very much age adjusted, and the risk goes up a lot as people get older, contrary to what we might be taught. And in women, the risk is lower than men, particularly the premenopausal phase. So the pre-test probability in younger patients is only 2%. So the CDR would perform very well in this age group. So think about it, you multiply that negative post-test probability, that low post-test probability and the low pre-test probability, you end up with a very, very low risk. All the patients, it's rubbish. So what's the conclusion of all this? We now know in a big UK cohort, I mean, almost 3,500 patients, CT reported by general radiology within 6 hours is very, very good, but it's not perfect. But there is a very low post-test probability. So if it's done within 6 hours, you're only looking at a 1 in 200 chance that you missed the subarach, and that an LP is going to help you along. A much smaller proportion of those had an aneurysmal bleed. So the question is, if someone's had a subarachnoid hemorrhage, that's great, and they might have a headache, they might be unwell, but the risk of rebleeding might be much, much lower if it's a non-aneurysmal bleed. And that risk was even smaller in some with a negative CT within 6 hours. And that can be part of your discussions. The clinical decision rule does have a high sensitivity, but the problem with that is it doesn't really impact the post-test probability, because the pre-test probability is so low. So that is the difficulty with many clinical decision rules. As a result, it might not be that great in ruling out subarachnoid hemorrhage without a CT scan. The authors mention a survey that was done of experts in the relevant areas, and they found a post-test probability of 2.8% after non-invasive and 1% after invasive was acceptable, just to give you the context of what we think is reasonable. They looked at what the post-test probability of CT was with time. So, of course, the sensitivity of CT went down, but so was the likelihood of finding a significant bleed, for the simple reason is that it was self-triage. So the longer patients wait, the less likely they're going to have anything significant. So this is something that emergency physicians have noticed in other studies. So patients will wait longer to present, quite often have less significant illness, and this is no exception. So if you match those two up, those presenting later, the CT is less good, but so is the severity of their condition also less severe if you match it all up. They did conclude the CDR was insufficiently sensitive or specific to be recommended as a rule-out test, and therefore we can't really use it. So this is from the authors. They looked at data from almost half the UK Type 1 emergency departments, and that is a very, very rich data set. And they collected data prospectively. So when the patient was still in the department, they used a data collecting tool to make sure they got all the information. Unclear causes were adjudicated by an expert panel, and they followed patients up for 28 days. So if someone's going to rebleed, they're usually going to do this within a week or two. 96% to be precise. So anything that happens afterwards is probably not clinically significant. It might reflect something else. They looked at usual care pathways. At the time of the data collection, we were still doing a very large proportion of LPs in negative CT. So that gives a very, very rich data set with regards to what does the CSF actually show. There is a concern that spectrophotometry, so what we do in the lab with CSF, might actually be overly sensitive, and that we're diagnosing bleeds of absolutely no clinical significance. And this is a concern from the literature that we sort of have to keep in mind a little bit. What did the study not address? It gave us a lot of pointers, but it does not say definitively whether CT is definitely more sensitive for aneurysmal than non-aneurysmal subarachnoid hemorrhage. And this might have prognostic benefits. If someone's a non-aneurysmal bleed, they might just be fine. They might not rebleed. You treat their headache, you rule out an aneurysm, then they go home. So what? Because we know the mortality is lower, non-aneurysmal subarachnoid hemorrhage, and neurosurgical intervention is rarely required. But the study doesn't answer that. So on my personal review, I think there's a methodologically very robust study using real life data from a lot of emergency departments, a very large data set that I believe is really relevant for us. And I'm going to come to why I think this is something we should all be aware of. One thing that isn't mentioned in the study, but is actually important to realize, that after 18 hours, the post-test probability goes up to 1%. But actually the confidence interval at this point goes up to 4%. And there's going to be no doctor in the land was going to say 4% is acceptable for a missed subarach. And that's sort of discussed by the by in a blog by some of the authors on the St. Emlyn's A&E blog. So takeaway messages. At Medics for LP, someone was coming with an acute headache. The CT is negative. The agenda is we need to still rule out a subarach. One thing that I found very interesting was that, of course, they looked at patients with headache that developed within the hour to maximum intensity. And 78.9% had peak intensity within 1 minute. So sort of the fairly conventional definition of a sudden onset headache. 90% had it within 5 minutes, but there was a remainder, and we're talking about 10% of all these patients had a longer time between onset and peak intensity. So you can't really say, oh, they didn't have a subarach because it took almost an hour for them to get a severe headache. And I think that's a very painful thing to read, because I think all of us have said, oh, it took almost an hour to get a severe headache. No, you can go home without an LP. I'm not sure if we can say that. And I think for us, that means some of us are probably going to be doing LPs on patients we wouldn't have done LPs on previously. What the data doesn't show in the paper, and I found this a bit irritating, was that they did not distinguish between aneurysmal versus non-aneurysmal subarachnoid in the true thunderclap one. So that cohort with a 78.9% were presented with a headache that was severe at onset within a second of first being apparent. The authors in their blog post mentioned that there is a hypothesis that, of course, an aneurysmal bleed is going to be more sudden and more severe because you're dealing with arterial blood. If an aneurysm leaks, you get a big spurt of arterial blood into the subarachnoid space. And of course, that's going to cause much more sudden symptoms, and a venous bleed is often much more slow developing because the pressures are significantly lower. So aneurysmal subarachnoids, is it more blood and more quickly? So of course you're going to get more symptoms. The paper does not actually tell us that, which is a bit irritating. All in all, 1.26% of all LPs that were done in the study were positive. So they did over 2,000 LPs and only a very small proportion was positive. CT negative within 6 hours of onset, the positive probability of subarachnoid was 0.5%. So the remainder were in later presenters, or later scans, I should say. So the NNT-LP, the number needed to do a lumbar puncture, will be 200. And they even said that the subarachnoid an aneurysmal etiology was even less likely, namely 0.1%. So you need to do 1,000 LPs to diagnose an aneurysmal bleed. So why am I presenting this study? It's all about the conversations we have with our patients, because they've come with a nasty headache. The CT was all right. They're getting a bit better with allergies. They might actually be asymptomatic by the point you see them. Do they need an LP at all? So based on what we've just heard, the CDR is not useful. CT may miss cases, even within the first 6 hours, but the number needed to LP is absolutely horrendously high, particularly in the early presenters. If we see patients on SDEC and the CT hasn't happened yet, we should probably do it if we think that the onset was very rapid. So within the hour, I don't think an LP is avoidable. So what do we need to do? We need to explain to our patient, first of all, the implications of a negative CT. And I think we should be prepared to quote these statistics. If the CT was done within 6 hours, there's 1 in 200 chance they've missed a bleed. If the CT was done later, you're talking about a 1 in 80 kind of thing. Because there are harms. And the problem with lumbar puncture is as follows. It's often done by relatively junior resident doctors. It's often more than one attempt, and there is a risk of harm. And as per the most recent guidance that come down through the courts, we should be prepared to sit down with our patients and talk about rare risks. So when physicians are not particularly trained in this, because we consent relatively rarely, but if you do an LP with a patient, and you should be asking, would you like to hear about the rare risks of this procedure? And the patient who says yes, you're going to have to talk them through the potential of all the stuff that can go wrong, which thankfully is awfully rare. But there is a paper from 5 years ago in JAMA where they calculate the risk of spinal hematoma after an LP in the absence of coagulopathy of 0.2%, or 1 in 500. So the risk-benefit calculus becomes really tricky. Most of the time, we don't cause hematomas. What we do cause is post-dural puncture headaches, which are shockingly common. Most of them don't get readmitted, although they might turn up on SDEC holding their heads and saying, okay, you've given me a different headache for another. Thanks, mate. And the high-risk category is the younger female patient. Of course, we can do things with our technique to minimize the risk, but it's still going to happen, isn't it? What do? We replace the stylet before withdrawing the spinal needle. We use the smallest needle size available, ideally 22 gauge or less. We use atraumatic needles if they're available and if you've had the training, and we should try and minimize the number of attempts. Yeah, right. What do you not need to do? You do not need to lie your patient flat after an LP. It doesn't work. It's a waste of time. We've known this for quite some time. So they can mobilize afterwards and go to the bathroom and etc. Lying them flat does not reduce the risk of post-dural puncture headache. The amount of CSF you remove has no bearing on the risk of post-dural puncture headache, because it's the volume of the ongoing leak afterwards that matters. Similarly, rehydrating patients after the LP is also probably a waste of time. So encouraging them to drink is just going to make them want to go to the loo. There is now, I found out this morning, a international consensus guideline on posterior puncture headache. So if you want to look that up, there's a paper from 2 years ago. It's an international consensus guideline on what to do with this condition if you've caused it to your patient. Another nugget that raises its head frequently on AMU is, okay, so we can't get the LP, the patient doesn't want an LP. Should we be doing a CT angiogram on every single patient with a worrying headache? We can't do an LP, it's technically difficult. So 2 of the authors met with representative of the Society of British Neurosurgical Surgeons. These are the guys you make your electronic referral to when you've made a diagnosis. And they reported on this in their blog. They are very concerned that we do too many CT angios on patients we don't need them. Because if you find an aneurysm, that doesn't mean it's bled. Particularly if the headache history is not all that great and you're just covering your backside. Imagine if you find a small and posterior circulation aneurysm and you don't know if it's ruptured. What's going to happen now? The patient knows, you've told the patient, oh, we found this little vascular lesion. They need to start getting into surveillance. They might be severe anxiety about a ticking time bomb in their heads, and they might eventually come to unnecessary intervention and a risk of peri-procedural stroke or other harms. So the neurosurgeons hate us doing CT angiograms without a good indication. And they really prefer us to formally diagnose whether there has been a bleed to begin with before we even take that step of doing a CT angio. So we will therefore probably continue to offer lumbar punctures in patients with rapid onset headaches where we cannot rule out a subarachnoid hemorrhage with CT. We really need to start using, for those who haven't yet, atraumatic spinal needles. And this is something that's been an international consensus guideline for 7 years now, but the implementation has gone rather slowly in various places, including our own centre, because I think it's got to do with who teaches whom. Most lumbar punctures done in medicine are done by a resident doctor under the supervision of a more senior resident doctor, often a senior IMT or a medical registrar. And in our current cohort of resident doctors, the use of atraumatic needles is simply not yet embedded unless people have done ACCS and have been to theatres and know how to use atraumatic spinal needles for neuraxial anesthesia. Locally, one of our SPRs is working very hard to try and get it embedded and hitting all sorts of roadblocks along the way. It's an interesting process. So hopefully in the next few years, physicians will be using atraumatic needles more and will be causing less of this, namely the posterior puncture headaches. But we do need to keep on talking to our patients. This is why we do DLP. We want to see if you've had a bleed. The likelihood of finding a bleed is fairly low, particularly if the CT was done early. At the moment, if you don't want the lumbar puncture, this is the risk you take by not having it. So using the consent standards and Montgomery, we should be explaining to our patient, what if you really do not want that needle? Then this is the risk you're facing, which can be anywhere between 0.5 and 1.26%, depending on the timing of the scan. It's all about shared decision making and speaking with our patients. And of course, to leverage this, we should also explain if you have rebleed in your die and we've missed an opportunity, that's the reason why we're putting you through this. I'm going to stop now for questions, and I hope there's going to be some questions. It's a fascinating subject, and I hope you've all learned something, particularly about how we speak with our patients, about the timing and the conduct and the sensitivity of LP for nasty headaches. I'm also going to open the chat so I can see any written questions as well.
Thanks, Jacob. Well, while people are thinking about questions, I just wanted to say thank you very much. I think it seems like it remains a complicated topic, but certainly the information you provided us will be really useful in decision making and, as you said, communication with patients. So I found that really interesting. Thank you.
So a question from Lucia in the chat. Just one of our AMPs in acute medicine. Usually a lumbar puncture is not needed if the CT is positive. Very occasionally there is doubt on whether the CT is actually showing a subarachnoid. So if the CT is equivocal, sometimes, so that gets referred to the neurosurgeons, and they will have a look at it, or sometimes with their neuroradiologist. And they sometimes come back and say, how about you do a diagnostic LP? Because if that's negative, we can put these findings to bed as a false positive. So those who've got a positive CT, generally speaking, an LP is not required. The question is what we do with patients with anemia. So that was actually a big learning point for me. I had not appreciated that the sensitivity of CT may be lower in patients with a hemoglobin under 100. So Abdullah Khalil, one of our consultants at Northwick Park, he's put a note in the chat. Actually, the Americans have actually adopted the same guidance with regards to CT within 6 hours. That might be because Perry published his study in the Stroke Journal, but with a very important caveat that there can't be any neurological deficit, which is sort of not the subject of our study. Literally, you've got your hand up.
Yes, yes, Jacob. Actually, it's about the lumbar puncture, more on logistics. That lumbar puncture, if you want to check for Santochromis, only we have a cutoff time of 4 o'clock. So in case these patients don't meet the cutoff time of 4 o'clock, would you really advise for the patient to be admitted?
It's a fabulous question. I didn't cover it in my talk because it's a local problem, really, that we do not have round-the-clock spectrophotometry. I think it's worthy of a conversation with patients. I mean, of course, until you've got a negative LP, you haven't ruled out an SAH. And until that time, you can't tell for sure whether they're going to rebleed or not. A lot of patients say, can I please just go home? I feel a bit better with pain relief and I just want to go lie in a dark room and have some home-cooked food, rather than be admitted to AMU overnight where demented grand next door is going to keep you awake. I think it's got to do with shared decision-making. My practice currently still is to actually admit these patients. And I think my colleague Dr. Bell has just made the same point. But we now have some nice UK-based data on the risk they might be taking by asking to be discharged, and we can have that conversation and say, listen, the probability of finding something on your LP is X, and take your risk if you wish, but this is the kind of risk you're looking at. Yeah, another point about the distribution of blood on non-aneurysmal subarachnoid hemorrhage. So Dr. Khalil in the chat, it's often distributed differently, so perimesencephalically. Hopefully that wasn't missed in the study because they had adjudication of the scans, but it's a valid point. David, I'm going to scroll back to the slide about the. I think that tried to put our mind at ease about the low hemoglobin. So they only had 36 patients with low hemoglobin, of whom 3 had a positive LP, positive CT, and 33 all had negative LP. So most of them didn't undergo LPs. Those who did had negative LPs. So I think the jury is out, unfortunately. But I've rolled back to the slide. And I think Will makes a really good point that sometimes we need to put it in writing, particularly if there's a language barrier. Can we actually just put something in one of those diagrams with lots of little humans, with one human half shaded to reflect that 0.5% of post-test probability for CT. Again, that will need to go through approvals in each trust, etc. But it's a very, very interesting way of communicating risk. There is a hand up from Dr. Baruch, who was one of the biochemists at Northwick Park. What would you like to add?
Yes, thank you, Jacob. Thank you so much. Thank you for a lovely presentation. My name is Yetunde Baruch from Biochemistry Consultant Chemical Pathologist. Just to mention about xanthochromia, if you do have a patient Monday to Friday, you want to do xanthochromia, please bleep us, because last week I was able to arrange for xanthochromia for a sample that came at 4:30. So it's not really it's really 9 to 5, but we expect the sample to be in the lab by 4:30. But even after 4:30, if you bleep us on 677-2677, we could still arrange for someone to do it. So it's not strictly 9 to 4, but really 9 to 5, 5:30, there would be somebody. And then at weekends, we have a service out of offsite. So if you, for example, if a patient comes on Friday, we can arrange for the sample to be analyzed on Saturday and Sunday, not on site, but off site, and we usually get the result on the same day. So we do have arrangements. Please bleep us. And even if we would try to get the lumbar puncture done, even at the weekend. But
Perfect.
bear in mind, the weekend, just let us know. You need to, on Saturday, Sunday, you can call myself or my colleague Natasha via switchboard, and we can arrange for it to be done off-site Saturday, Sunday. And Monday to Friday, just bleep us. If it's 4 o'clock, bleep us, and then we could arrange for someone to at least wait till 5 to do the analysis if the sample gets to us by about 4:30. Thank you.
It's got to do with technician skill in the lab.
Yes, exactly. And also because you would appreciate that after about 5:30, there's a lot of concentration on getting A&E work done, from the automated analyzer. So there's less staff to do it between 9 after 5:30, but more staff between 9 and 5:30. So that's the rationale. But please do bleep us even when it's 4 o'clock and you really have a patient, you need to do lumbar puncture, and we'll try as much as possible to get someone to do it.
Excellent. We'll spread the word.
Yes.
Okay. With no further questions, I'm going to wrap up. Thank you all for listening, and I'm looking forward to the next installment, which you'll be contacted on by the usual channels. Thanks, everyone. Bye.
Thank you.